The following is brought to you by VerticalVet. Rethink your GPO.
Hello, Vertical Vet family. I am Dr. Ernie Ward, Chief Veterinary Officer for Vertical Vet, and it is my highest honor and privilege to bring you another episode of Vet Med School. And this week it is sponsored by our friends and partners at Movara. And I got to tell you, if you are interested in anything and everything surgery and surgical instruments, training, whatever, you want to talk to them. And that's what we're going to be talking about today. What are the surgical procedures? What are the impacts even of not doing certain things in general practice? And look, I grew up at a time when I was known as the knee guy. And I think that too often, general practitioners are just sort of forgetting the art of surgery. And today we have got a very special guest who's going to talk to us about really the impacts it has, not just on our practice revenue, but also on our patient care. And so we're going to talk about this, what he would say or describe as a gap between the veterinary care between general practice and surgical specialists. So without further ado, I want to introduce you to a dear friend of mine, whom I have known for a long time, just been also a very instrumental, always a person who helped me out whenever I needed help, and I can't thank him enough for all those phone calls over the years, but Dr. Randy Basinger, and he is a graduate of Ohio State University, go Buckeyes. He completed his internship in Boston, but then he really got serious about his education and went down and did his residency at my alma mater, the University of Georgia, go Dogs. Then he went up to Columbia, South Carolina, and that is where I first really became aware of him, because he was not only generous with his advice, but just doing remarkable surgical advances back in the day, and he's never slowed down. His wife also, if you're interested, is also a veterinarian. She's general practice, and his son and his wife are also veterinarians in South Carolina. He's, of course, you've read his stuff in multiple textbooks, all over the surgical world. He's also been involved with everything in South Carolina State VMA, and he was also involved with chairing the ACVS, or the American College of Vet Surgeons Foundation, for 5 years, and he is right now the president-elect of the Veterinary Orthopedic Society. Randy, I got to tell you, it's my highest honor, to have you on the webinar today, because you probably remember a lot of phone calls from me 25, 30 years ago. Man, you always took them. I can't thank you enough.
My pleasure to be here.
Yeah. Well, listen, Randy, one of the things that you taught me early, and I think that you've really impressed an entire generation of vets, is that a general practitioner can do a lot of surgeries, but yet we continue to see this gap. We continue to see more and more veterinarians who are unsure and, lack confidence in their surgical skills, and they're referring things that, quite frankly, I think they are capable and competent to do. And so you really describe this, as this care gap, right, between these patients that are kind of falling in this gap, and they can't afford to go to a specialist, or don't have the resources to even travel to the specialist. Therefore, they don't get the care they receive. So maybe let's start off with that. When you describe it as this veterinary care gap between general practice and specialty hospitals, what do you mean exactly by that?
Okay. So that's where I became interested in this. And I did write a white paper for Movora of kind of defining the problem. And I think there's 3 key points. And because of the white paper being as succinct as I can possibly state it, I think I'll just read those key points, and after that will be extemporaneous. But I would like to preface it by introducing that I am a surgeon. And so because of that, I think this problem that I've identified and we're talking about today is probably magnified more with surgical things than potentially like with radiology or maybe some other disciplines. But anyway, the concern is that there's a worrisome and worsening trend in veterinary care delivery that's being discussed more and more frequently by veterinarians and pet owners. And that concern is that there's a large segment of the pet owning public that wants to do something for their pet's condition, but is unable to pay the cost of treatment at a referral level by a specialist. But when they request their family veterinarian to help them, they find that they are not trained or equipped to handle that surgical problem. And this is becoming more problematic as the older generations of veterinarians retire that actually were trained and encouraged to do some of these common procedures while they're in veterinary school. The second point that we have to agree to is that veterinary specialty hospitals are certainly abundant. So there is access for those that will go, but they are very expensive and getting more so. And I've done nothing but specialty surgery practice for 30 years, so I've definitely seen things that used to be a $600 procedure become a $6,000 procedure, and pricing it out of the realm of, you know, possibility for some of our clients. And then the final point, at the same time, veterinary teaching hospitals are managing the kinds of cases in surgery that do not give veterinary students a good foundation in treating the common surgical diseases that they will need to treat in practice. Referring cases to specialists rather than performing them themselves is what's emphasized, and this wasn't always the case. Because of the lack of referral options, when like Ernie and I went to school, we were encouraged to learn how to take a kidney out and to do a gallbladder removal if necessary, or an MLP. But now that's not taught because there's not time and a desire to do that. So as this generations of veterinarians retire, that leaves practices without somebody to do that. So that's how I've identified the problem. And I think we can talk about evidence for that in a second, Ernie, but so throw that back to you.
Yeah, and I really appreciate that because that is succinctly describing the problem. I mean, that is it in a nutshell. I mean, basically, hey, there's access to these clinics that weren't there in the past. The cost barrier is now really becoming an issue, but more importantly, there's not a foundational learning, right? So these vet students really aren't being exposed to these skills. And I would say I'm in complete agreement with you also, Randy, the fact that they're being almost discouraged, right? I mean, so I had a young veterinarian not long ago. I mean, this was just a couple of months ago, who was referring out for a urolithotomy, bladder stones. And I'm just like, I'm bewildered, right? I'm like, why?
Yeah.
And she says, well, there were a lot of stones in there. I'm just kind of going, wow, okay. Yep, that's the condition. So Randy, how can we, so like right now, let's say that there's somebody watching this who's a manager and owner of a clinic, and they've got a young associate, and this associate is reticent to do even a bladder surgery, right? I mean, so I think that's very within our realm. What would you say are the steps we can do to help that young associate gain some confidence, right? I mean, because I've got my little list of things that I did with my associates, but from a surgeon's perspective, what are the things that you could do to encourage them to gain those skills or to get confident? Because let's face it, Randy, they're not even going to go take a CE if they feel like, wow, I'm so uncomfortable doing this. So what's your tip?
Okay. Well, I think the first thing is to agree that it's a problem. And there is some recent evidence for that. Two papers have come out recently in Veterinary Surgery, our main magazine. One was 2015, so a little bit older, but they looked at 1,000 veterinary practices, and they looked at specifically the problem of anterior cruciate ligament disease. And the thing was, well, how many of these cases got referred? How many got managed in their primary care practice? And despite them being offered referral in all cases, 80% of the cases chose not to go for referral, either for cost or, commitment to their family practice veterinarian or whatever reason. And so the bottom line was, 80% of them got handled by their family veterinarian. So we do about 1 million cruciate and knee surgeries a year in the United States. That means 800,000 of them are managed by general practice veterinarians. So we've got to be able to help these patients and the people who love them with their pet, or else they're not going to get managed. At least 80% of them aren't going to get managed. And the other paper that came out just last month in Veterinary Surgery was an interview of veterinarians that were first-year graduates and practices that employed them. And the questions they wanted to know is what level of comfort did they have in basic surgical procedures? And the first-year graduates almost all said that they did not comfortable doing a dog spay or a cystotomy or an enterotomy by themselves with their level of training. And the practices that employed them also had the same feeling, that they didn't feel comfortable that those people had the skill sets to do that. And that's sort of frightening because what that means is that they get mentored by the veterinarian that hires them. And if she or he is up to date on the current things, then an apprenticeship or mentorship model works well to train them. But if they're not, then they're not going to get good post-DVM training.
Right. And even then, Randy, I would go back one step and I would say if the existing owner or the head surgeon or whoever in the general practice is, and they don't trust that that person, that new associate has those skills or even the interest, then I would say they're less apt to actually try to train them in any way, shape, or form. So, I mean, I think this is a deep rooted problem. So, Randy, one of the things that we really tried to do early on was to actually create the time, make the time for me to sit in on as many spays and surgeries. In fact, during the first 90 days of a new associate, they had to be in the surgery, 10 different spays, right? And of course, neuters and anything else came along. But we had a checklist of cases that they had to watch me do. And then after the 10 were observed, I did 10 in support. And Randy, I think that it's really the structured approach to getting your hands in that cavity and actually feeling the tissues and exploring around, and I'll tell you, so if you're sitting there saying, gosh, I've got these young associates and they don't want to do surgery or I don't trust them to do surgery, have you actually trained them at all? The other thing too, Randy, is I think we get so busy that we don't take that opportunity maybe to extend that incision a centimeter on either side and actually take a peek up there. That's the spleen, that's what the tail of the liver looks like. Over there, you might see a little kidney, right? I mean, we don't even take the opportunity to give them that confidence. So, I mean, that's sort of been my thing, is to have this structured sign-off checklist of things that I did with associates. Any techniques or tactics like that you tried?
No, I think that's excellent. And that's actually how I learned to do spays and that sort of thing too. But the concern with the apprenticeship or mentorship model is the person who's getting the training is only getting training as good as what is offered. Now, if that's for a spay or a cystotomy or something that most general practice veterinarians with experience, remember I'm married to one for 30 some years and my kids are them, I mean, I'm very attuned to what goes on in general practice situations, then that's great. But we're talking, I think what I'm hoping anyway, is that we get kind of the next level of procedure difficulty comfortable for these young veterinarians too, like being able to biopsy a liver lobe or take out a gallbladder if they're interested and have some aptitude in surgery, or doing basic orthopedic surgeries like MLPs or OCD that they never saw in veterinary school because those cases don't go to vet schools.
Yeah, and I love that. And again, guys, this everything that Dr. Basinger is saying, these are procedures that we are capable of doing. I mean, so this is stuff you can go and take advanced CEs and learn to do a wide variety of things. And Randy, that's our next point that we want to talk about. Okay, so we've just kind of hinted around some of the issues of why, but what about the impact on our patients? I mean, I think you alluded to this in your earlier some of these papers, but what's really happening to these patients who need advanced surgical procedures and aren't getting it for a variety of reasons? I mean, explain a little bit about why this is important to us as far as just caregivers.
Yeah, well, that's why I'm very involved with this and love to do post DVM wet labs and training for vets, is because based at least on ACL disease paper where we have some data, 80% of the patients are going to continue to be managed in their general practices. And so I get very frustrated as a referral surgeon if somebody opened up an abdomen thinking it was a spleen they had to remove and there was something wrong with the liver, but they didn't feel comfortable or able to do a liver biopsy. Or they got in there and, it was really a gallbladder mucocele. And, if somebody's had several years of surgery under their belt doing spays and neuters, they have the hand skills to do that. They may need the training and the confidence building to do that extra little bit that might be needed. But, I want our patients to receive quality care. And for those that can't go to referral practices, to have it done well in your practice where it's good for the patient, good for the owner, and really good for the economics of the practice as well.
Yeah, and again, Randy, a lot of these cases need surgical treatment, right? I mean, so GBM, that's very difficult, challenging to manage that medically. I mean, I'm not saying it can't be done, and there are definitely
Right.
some protocols in place, but I don't know if you're seeing this, but GBM seem to be on the rise, gallbladder
Yeah.
mucoceles, but they seem to be on the rise. And again, that's a surgical fix that's, I think, like you mentioned, well within our expertise and comfort level. I mean, if you can handle soft tissue, you can do it. Randy, I used to always tell my young doctors, it's like, if it's in the abdomen, we can do it. I mean, I'm exaggerating a little bit, but I think that sentiment is being lost, right?
Right.
So, Randy, let's talk a little bit too. So, patient care is one thing, but let's be honest. I mean, there's also an economic, cost to not doing these. And again, Vertical Vet family, that this is not about revenue. This is also about patient care and actually, developing expertise. And I believe this leads to job satisfaction. But let's face it, Randy, this costs a lot of money to the clinic. I mean, so maybe you could walk through. I know you've got some examples prepared of things that you say, hey, look, if you're not doing these procedures, you're actually losing this much money.
Sure. I created a couple of examples. Let's pull up, Gastropexy. This is something that we often get referred, or I hear a lot of GPs when we teach soft tissue surgery wet labs. I mean, that's like one of the top things that they want to do: liver biopsy, gastropexy, gallbladder removal. And so I said, well, let's look at what happens if you refer it versus if you do it in your practice. And so if you refer it, probably a reasonable estimate for a specialty practice, depending upon where you live, maybe $1,500 to $2,500. And if it's going to be done laparoscopically, it's probably going to be more to that. So your practice doesn't have any expense, and with everybody busy, it doesn't tie up any time. So that's maybe a value. You also get no income to your practice, which is bad. And your client has to go somewhere to meet somebody they don't know, maybe don't trust, and maybe lose a little confidence in your practice because you weren't able to do what seems like something maybe you ought to be able to do. So next slide. If you decide you want to do this in your practice, and for this and the other kind of next level surgical procedures, I think practice owners or managers should pick somebody in their practice that has an interest and some aptitude in surgery and go ahead and build up and mentor this person. So let's say, well, there's nobody there that can teach them. So we're going to take a wet lab half-day course to learn gastropexy, make up some costs, maybe $450 for the wet lab. A lot of times they're actually sponsored by companies, and so that's not a cost. Maybe $175 for hotel if you spend the night and some meals. But you maybe have a one-time expense of, say, $750. So next slide. We're going to make some assumptions. You're going to charge $900 for gastropexy, and that's going to include anesthesia, hospitalization, meds, everything. Maybe a little less if you add it as an add-on to a spay or a neuter. And assume that's 25% of the cost of that is going to be expenses: doctor time, drugs, supplies, tech. So each time you do one of these gastropexies, you're going to get $675 a procedure. And if you do one a month, and I'd like to throw in the don't forget you should be doing them with most splenectomies because that's recommended, you're going to have an annual profit of that procedure of $8,100. I don't think one a month is by any means too much in terms of numbers. You have a one-time cost of $750. So that first year, you're going to generate a $7,350 of profit that you wouldn't have otherwise. And I think that's being very conservative with the number of gastropexies that you might do. So we also did and yes, importantly, how many of your patients won't get that done because they won't leave your practice for a referral because of distance, commitment to you, whatever, or they balk at the cost. And we want our patients to do what we want them to do, right? We want our clients to get their patients treated. So, and I gave one other orthopedic example that I think is something we do a lot of these wet labs, and most practitioners feel comfortable being able to offer this in this practice after a lab. But if you refer that patient, the cost to client might be $2,500 to $4,000, maybe more. Same thing, zero income, zero expense, didn't take up any of your time, which is, I know, at a premium right now, but that's if you refer it. If you decide to do it in-house, but you need to send somebody or learn it yourself to be able to offer it, we're going to do the same formula: $450 tuition course for a half-day wet lab. But in addition, unlike gastropexy, you might need some gear that you don't have, maybe an electric drill and a shroud, pins, wire, rasp or saw, bone cutting forceps. So maybe $1,500 worth of new equipment. Same thing with the hotel and meals, but your one-time expense might be a little bit higher at $2,250. So next slide. And then you're going to charge $1,400 for the procedure, which will take you less than an hour. Same thing with the expenses. We're going to call it 25% of your charges for the cost, which will give you a profit of $1,050 procedure. Let's say you do 10 a year. That's not even one a month. Minus your one-time cost, that's $8,250 of profit to your practice that you wouldn't have plus the same things as before. Next slide is that you're doing it in-house, and that way those clients are going to have more confidence in you. You should be consistently successful with gastropexies and MLPs and even lateral sutures if you pick the right cases. So they're going to be high client satisfaction procedures. And with this particular scenario, the MLP, you have new skills and some equipment that you can use on other types of orthopedic cases.
Yeah, Randy, I love these examples. And I'll say right now, I was that first wave of GPs where we started pexing everything, and not everything, but, certainly at-risk breeds and so forth. And anything that ever had a splenectomy, you always pex it. So I appreciate you reminding everybody of that. But that was a relatively simple procedure. And we just started baking it into, spays and neuters, at-risk breeds at the time. And it was a moneymaker. I don't know. I mean, I'm sorry to be blunt about it, but, this was, and it was a rewarding procedure. Clients came to expect it. We wound up getting so many new clients, right? Because they were like, oh, my vet doesn't even know about that, right? And I know that was a different time, but the reality is, Randy, this grows your practice on so many levels. Plus, the other intangible, if you will, is this brings a lot of pride to your team. You know what I'm saying? Like when you're able to do these kind of things, like your team, they get very, very proud of that, and that makes them enjoyable. Yeah, they do get jazzed. Now MLPs, I'll be honest with you, I took a course, Denny Aaron's course back in the day. Dr. Dennis Aaron back, was a guy that both of Randy and I worked with. He was a professor, and I did a bunch of them, and that we were doing rasping and trochanteric, but that one I never really embraced as much as I did some of the others. Obviously, back in the day, doing a lateral sutures, the imbrication procedure for knees, that was a great. I was not joking. I became the knee guy in my area. Now, obviously, TPLOs changed that, but maybe you could just reference a little bit about that, because I think that a lot of times vets today, when you say cruciate, they instantly say, some kind of leveling procedure. Can you maybe explain that? Just give me your opinion on that.
Okay, I will, because we do an awful lot of these lateral suture wet labs. And lateral suture with the newer modifications, with new suture materials, different bone anchors, but even the nylon leader line and crimp system, it's still a very valuable procedure. It's pretty darn isometric. It's pretty darn strong. You just don't want to pick a patient that's got a very high tibial plateau angle, a very active large breed of dog, somebody who's expecting an upper echelon athlete out of their pet. It's all about picking the right sorts of cases, but not everybody can go for a TPLO. And I think, Ernie, you will remember that we helped an awful lot of dogs that were huge dogs, that were athletic dogs with lateral suture. It's just not as good as TPLO. So just making sure you pick the right patient, I think, is the best. And you brought up another point that I want to emphasize that I think is very important. If you want to set your practice apart a little bit from the other practices in your area, one thing that is not as prevalent as it used to be as specialty practices came into some of the smaller towns is there used to be that practice that was like, oh, well, if you can't go to the University of Georgia to get your osteotomy procedure done for a TPLO, well, Dr. Ward is, just down the street, and he does a lot of the knees on cases that really can't go there or maybe are good candidates for lateral suture. And it makes Dr. Ward's practice look, a cut above everybody else's. And that can be your practice for certain types of procedures, whether it's gastropexy or whatever. If you get the training and the equipment and you start doing it, tell your friends at the local association meetings, yeah, we're doing lateral sutures now. If somebody gets stuck and they can't go for referral, we've taken the courses, we're offering that sort of thing.
Yep, and I love that. And again, I'll never forget, there was a young veterinarian. This has probably been at least 10 years ago. And you'll recognize what I'm about to say. And he was setting up a new clinic. He'd been in practice for a couple of years, but, it was kind of just in, growth malaise, right? I mean, he was growing, but not at a rate he thought. And he was a little concerned about economic pressures and competition, all that kind of stuff. And I was like, well, look, what you've got to do, and excuse my grammar, but I said, you got to go where they ain't, right? I'm from South Georgia, so that's what we used to say. So I said, look around you and see what procedures they're doing or not. And so, in his area, they didn't have a surgical specialist or whatever, but he didn't like orthopedics at all, right? So he was like, nope, I'm not going to start plating and, putting fixtures on and all that stuff, although I love fixtures, by the way. But anyway, I said, one of the things that you might want to consider if you don't like it, this is a tricky surgery, but you could really set yourself apart. I said, learn one thing really well that nobody else is doing. Talked him into doing some tracheal stenting. So he went and did a couple of courses, and he became known as the breathing guy, right? And his practice started just taking off. Now, you see where I'm going with that, Randy, right? He find something maybe you're the knees, maybe you like to do pexies, maybe you like to do, I don't know,
ear canal ablations.
Right. So, find that one thing, but, for him, stents worked out. The timing was good, right? Because these, we actually had developed some materials that you could actually put in there reliably. And so, Randy, do you ever give advice like that, like to find that one thing and hone in and get really good at it? Because I think then it branches out.
Yeah, it could be something simple like when Pen Hip first came out, and there weren't very many practices doing that. I talked to people in different cities and referral areas around South Carolina and said, if there's nobody in your area doing that, go take that course, and you're going to get all the breeders and the performance dog and the service dog people. And that's a very simple thing to do. But yeah, if there's something that you're interested in, pick that procedure, right? But do think about it, because you mentioned the breathing thing. I wrote an article for the National Bulldogger magazine probably 20 years ago. And all of a sudden, I was the bulldog upper airway surgery guy, and people were shipping them in for all over. And my staff was like, no, don't you ever do anything like that again. So you got to pick something that you like to do, and it's not going to come back and bite you.
Yeah, that's a great point. Well, and again, so I think you find that thing because what I found in my career for sure is that once you develop confidence and competence in one particular surgical area, you then feel more comfortable taking on that next challenge. And and again, I just people ask me all the time, what do you miss most about practice? And without hesitation, I say surgery. I love surgery. I consider myself a good surgeon. I love that challenge. And I like the reward too. I mean, I think one of the things for me, even though I guess, everybody knows me with nutrition and obesity, that kind of came a little later in my career, quite frankly. But, it's that instant gratification, Randy. I mean, you literally could see these dogs walking or being more comfortable, 24 hours later. I do love that about surgery.
Yeah.
All right. So the last thing we wanted to kind of talk about, obviously this is a big problem, right? Lots and lots of reasons why and lots of possible solutions. So talk to us, I know you've hit on a lot of this, but maybe sort of in summary, what are some of these solutions? And again, we're sponsored today by Movora. They not only have surgical, equipment, but a lot of training. They've got a couple of different dedicated facilities, East and West Coast. But, what are some of the solutions to this problem in your opinion?
Yeah. I think it's probably going to be up to industry to kind of pick up the slack in this area. I mean, I know University of Georgia last month did a feline surgery thing as part of their once a year CE thing that practitioners could come back to. But post DVM education, I think, is where we have to go with that. And, if you've been in practice for 6 months or a year and you've done a handful of spays and neuters and all that, you've got pretty much the same hand skills I do. You can handle tissue, you can cut tissue, you can tie a knot. You just might need, what's different about this particular procedure, what other piece of equipment makes it easy versus hard. And so getting that education and ramping all that up is what I'm very involved with at this point in my career because of that gap that we identified early on in this interview. So they do them at state meetings. Movora has been very good about sponsoring them. Some other companies do them, but there honestly is not enough opportunity. And I would like to see them done at a very high level versus we talked about the mentorship or apprenticeship model in your practice. And I'll be honest with you, I just finished, being chairman of the ACVS Foundation for 5 years. There's a lot of my associates in the college that don't feel the veterinary surgeon should be training veterinarians to do surgery. And I mean, my question is, if not us, who? We are the people who should be out there doing that. So I would say, if you have somebody in your practice that has an aptitude and an interest in surgery, and you pick some procedures that you'd like to add to the things that you offer and maybe set your practice apart, just look around on the web to find places that are offering wet labs. I mean, I think you can only do so much surgery-wise with a webinar. I mean, it pretty much has to be, okay, we're going to go through it didactically with a lecture. Now we're going to go to a cadaver lab and practice under the eyes of surgeons who, are trained in that procedure. But that's kind of why I threw the economics of it in there, because yeah, it might be an initial outlay, but it'll transfer to a lot of satisfaction, and most importantly, helping manage that maybe 80% of your clients that won't go for referral for certain procedures.
Yeah, I couldn't agree more, Randy. And I'll be honest with you, like going through and back in the day at Georgia, that external fixator course, that completely changed the trajectory of how I handled fractures from then on. I was putting fixators on everything. It was just like, come on, bring me your broken bones, and again, you get that little extra confidence. But if you're also sitting there and you're a manager and owner, I mean, Randy, I don't want them to ever overlook the fact that if you can be actually, encouraging them on the day to day, like say, wow,
Right.
that's a fantastic job in the spay. I really like the economic movements that you're using. I mean, whatever it might be, but just really be that support and nurturing, voice that they need to hear. Because I think too often the biggest limiter that I see in individuals, anytime, especially we want to progress, is just that little nagging voice that says you're not good enough. And sometimes somebody can just do it. And Randy, you did that to me on multiple occasions, because I'm not joking. I mean, guys, I was in Calabash, North Carolina, Podunk, and, I'd known him through my little network of mentors. And, I called on this guy more than once. And not that he actually, we didn't have videos. I mean, this was just regular phones back in the day. But, Randy, what you did more importantly, not only kind of give me a couple of tips here and there, but you said, you can do this. Like, I'll never forget that. And that would just give me that extra little boost, right? To say, okay, I can do this, because I had to do it, but
Right.
I can't thank you enough for that, because it really made a huge impact. Your kindness, your generosity, but also your encouragement, it really changed who I was as a surgeon during those early trying times.
Well, that's how it was back in the day. We had to do it. Now we
Yeah.
have the referral option, so we tend to sort of shirk our responsibilities sometimes as GPs. And so that's the concern is I'm so afraid of getting in over my head. And I think that's drilled in vet school, instead of, you got to wade into the water a little bit to see where you're starting to feel uncomfortable. And if you wade into your chest, the next time you wade into your chest, you're not so uncomfortable anymore, because I'm good in that area. And so stretching and growing in surgery requires us to, get training, but also have support behind us saying, yeah, you can do this.
Right. And Randy, you've done that for an entire generation, maybe generations, and I can't thank you enough. And I think you can see, Vertical Vet, why we like bringing you people like Dr. Randy Basinger, because, this guy not only is so, instrumental in developing a lot of techniques and really, forwarding the science of surgery and vet medicine, but he's also been the person who said, listen, we need to broaden who's actually doing this and not just do it in the ivory towers of university settings, but, I think you can do it. And that's something that the whole profession owes you a gratitude of thanks. So again, thank
Well,
you very much.
thank you for that.
Well, guys, that is it for another edition of Vet Med School. Again, this one was sponsored by our dear friends at Movora. So if you're interested, definitely let us know. We've got all kind of surgical wet labs coming up all around the country. So no matter where you are, we can probably hook you up with Movora. And more importantly, if you need surgical skills or just advice on stuff, then they've got it, because they sell some of the greatest surgical instruments on the planet. And honestly, what I tell every vet anytime they're asking about advanced surgical stuff is like, well, just call these guys and talk to them, because that's what they do best. So again, on behalf of the entire Vertical Vet team, I want to thank Dr. Randy Basinger for taking some time with you guys and us today. And anything we can do, let us know. I am Chief Veterinary Officer Dr. Ernie Ward. Been my pleasure. We will talk to you next time. Bye.